most of the time when we talk about diabetes, it is predominantly type 2 diabetes. And type 1 diabetes is, kept periphery. Really, we do not address this issue, probably because, we feel that is too infrequent, or it is like, a niche area which, even in our medical community, it is dealt with by endocrinologists, it is dealt with by those people who know the maximum about this thing. But it is really common. So if you see, when we did INDIAB in the country, we found that almost 11.4% of the population above the age of 20 years had diabetes, whether it is type 1 diabetes, whether it is type 2 diabetes or any other form of diabetes. We did not want to sort of segregate it. We just said 11.4% of the people in the country had diabetes. In Goa, the number, as Janice first only acknowledged, 26.4% of the population has diabetes. Add to it another 20.3% who has got pre-diabetes. Pre-diabetes stage where you say that there is a very high risk of developing diabetes. 26 plus 20 and then 0.3, 0.4, whatever. 47% of the population. Almost 1 in 2. So if there are 2 people sitting in the room and if they are from Goa and they are above the age of 20 years, one of them has either diabetes or pre-diabetes. Very scary scenario. That's the big picture about diabetes in the state here and in the country. If you look at type 1 diabetes, I remember my mentor Professor Tandon talking about these things many years ago when I was doing my training in endocrinology. So we looked at the entire people group who developed diabetes at a younger age as type 1. Today we are looking at them in a bit different manner. I would say that we should call them as young diabetes. Let's call them as diabetes of the young, DOY. And after that, let's sort of break them up into groups. There has been no real study in this country, at least, which looked at type 1 diabetes predominantly or primarily, trying to say, oh, these are people with type 1 diabetes. So the YDR is the registry which is looked after young diabetics. The prevalence of type 1 diabetes is probably somewhere between 0.5 to 0.8%. So 0.5 to 0.8% of the population would be having, approximately less than 1% would be having type 1 diabetes. Today, these numbers would change with time because we have done a lot of work on exome sequencing. Some of these people who were labeled as type 1 now do get reclassified as monogenic forms of diabetes. So in that sense, the numbers do change. But if you see ballpark figure, someone can say 0.5% of the population. 0.5 is a big number, let me tell you. I know it's not 25%, but 0.5 is still a big number. So 0.5% of the population has type 1 diabetes probably. How do we manage it? Like the predominant focus, I've spent 15 years here, and everyone who knows me would say, Ankush talks only about diet, and eat salads and eat vegetables and eat so-called, healthier foods. But that is the crux of the thing. You have to be disciplined in life. You have to, so I was just telling someone today that you need to reach out to the clinic regularly. So go to the doctor regularly. Do your tests regularly, both which you do in the laboratory as well as your self-monitoring. Take your meds regularly, that is insulin in this case, because that is the lifesaver in people with insulin-free forms of diabetes or type 1 diabetes. And then follow the discipline in life in terms of eating, time of eating, the type of food which you are eating, the amount of food you are eating, whether you are eating at wrong times, sleeping well, keeping yourself de-stressed, doing yoga, meditation. All these things play a big role in the world of type 1 diabetes. 2 things. The third thing which I want to say is comprehensive care. And Janice asked me, how do you take care, of diabetes using all the other things? You need to go to the eye doctor, get your eyes checked annually. You need to go to get a urine examination done, and if you need to go to a kidney doctor, you need to meet that guy also. You need to see to it that you take care of your feet, and you need to meet that guy also. Much more important than all of this is the role which is played by Natasha here probably, or Sushant and all my educators out here and others who are there. The diabetes educator is the central fulcrum of this care of diabetes. So they are the ones who are going to tell you how to lead your life. Whatever it is, we as doctors, we do just, peripheral, might be 20%, 10%, or even might be 2%. If the diabetes educator becomes the most important person and leads the show, our role becomes much, much lesser. And that is how you can lead your life of diabetes.
I would like to come back to Dr. Ankush once again. If you could please talk about the newer therapies available, especially the availability of free insulin and the insulin pumps that are now much available, and any other technological advances? How do you go about, how do individuals with type 1 diabetes go about monitoring their blood glucose? Okay, the different techniques that are available.
So here is Karthik, there is Divya, there is Shravya, there is Dhruv, there are so many others here who have spent a lot of years with me. One of the things which they always feel about me is, why does Ankush give them the injections? That's the big question which is there. So if you look at the world before insulin came, the world was not very pretty. Elliot Jocelyn used to treat his patients with young diabetes, whether you call it type 1 diabetes or anything, with just diet, diet and diet. Starvation diets. Do not eat this, do not eat this, do not eat this, do not eat this, do not eat this. That world was not good. It was when Frederick Banting showed the use of the most impure form of insulin which can be used in this world, that for Leonard Thompson, the world changed. He, from a shriveled boy, became a healthy looking, handsome child. And then he went on to live in this world for almost like 70 odd years. I don't know whether Logan knows about his story. So what I want to say is that with changing times, there would be many advancements. We have seen the world. If you ask me, I have seen the world when I started this journey in diabetes or endocrinology, that children used to monitor urine sugars. They used to come to the clinic at the Olney Institute, in the DOI clinics. They would get their urine, and there was this guy who used to sort of boil the urine and put the Benedict's, the urine to be put in the Benedict's solution, and then the color change, and this is the amount of glucose that you have in your blood right now or in your body right now. They would say. Times have changed. We have got human insulins, and now we have got a lot of analogs, and I guess many of them would be using the analogs. So the government of Goa has been very kind to see to it that we get the most modern forms of insulin here. So that part, I think so, all of you all should be extremely clear that we have seen to it. The minister has been very, very strong in this. Is let us get the best of insulins, and which are the most advanced ones. Be the analogs, the ones which we use, insulin aspart or the insulin deglutide. This is in the world of diabetes. This is the most advanced thing. We are going to get smarter insulins in future, but this is the best which is there right now. That is what is available in Goa. There is no doubt about that. That is as far as the insulins are concerned, and Novo has played a big role in seeing to it that we have got these insulins here also. The second part is, as I said, monitoring. We have mostly been doing previously urine sugar monitoring, and I remember when I came in 2009, 2010, at that time, there was hardly even a single patient who had a monitoring device on his own or her own. There was no one who carried a glucometer. It was very difficult for me to convince the people in the institute that you need to reimburse them for their meters, for their strips, and people told me, hello, people are not supposed to carry the meters home. They are supposed to keep in the hospital. They used to come and do their device maximum here in the hospital. But it was not very difficult for me to tell Mr. Rani that sir, if we need to get these glucometers, people have to be reimbursed these things. And today we find that almost everyone has a glucometer. That's still the journey which we've gone through. We have now seen, we have reached a situation where there is something called continuous glucose monitoring. I know Karthikeya doesn't do it. I guess Logan must be doing it, and there must be others in this group who are doing continuous glucose monitoring. Sort of it might appear sleek, it might appear something niche. No, I guess that's the way to do it. We need to see to it that most of our people get access to continuous glucose monitoring, and they need to use it regularly, almost continuously, because that's the way we are moving ahead. Third thing here is, we started off using one injection, poking the big needles. I remember at the online institute, people used to not use disposable syringes, reusable syringes, take the insulin and then inject again and again. Times have changed. Since I was in Goa, we have been fortunate enough, everyone has been using disposable syringes. We have had the access to the insulin pens right from the time when I have come here. The minister has been very kind to see to it that we have got these things. And I just hope that we start using the insulin pumps much more regularly. Erika is the only one probably who has the insulin pump right now. And I would want that we use the most advanced pump, which is the one which is available right now, which actually senses the glucose from the glucose sensor and closes the loop by giving the amount of insulin that the person needs. And if we can get AI into the field, we really do not need to do much amount of, the algorithms which is run in our head. Okay, how much does he need to take insulin in the morning, how much in the afternoon, titrating the boluses and all. That would be done by the pump on its own, learning the individual. It's not for someone else. This pump is tailored for this guy, because this pump has been with this guy for the last 3 months or 2 months and knows when does the sugar rise of this guy, which day does he do the cycling more, which day does he play badminton more, which day does he eat more. So if the pump knows that, the pump can use the previous knowledge to adjust the insulin doses accordingly. So that's where we are headed for. When I came here in 2009, there was hardly a single patient who used to do HbA1c. There was not even a single patient. It was so very difficult to convince the doctors that you need to do HbA1c, because that's the measure of glycemia for people. That is where we started off. It took me 15 years. And while I don't know how many people have changed and how many people have started doing HbA1cs, times have changed. With CGM, with the closed loop systems, probably we are going to see a time where we are now looking at how much time does the person spend in range. I've still not done to most of my patients here. I have hardly told them to look at time in range. But Logan would acknowledge and understand this, is that we have to see to it that we spend more than 50% or 70% of the time of these children in range. So we are going to see a situation that HbA1c is probably going to get obsolete sooner or later. We are just going to see TIR. TBR has to be kept less than 1%. TAR, maybe, some people might be 20%, some people might be 50%, 5%, but you have to see to it that you keep the time in range within, say, 70% or 80%. That's what we are looking at. So these are some of the things which we are going to see in the times ahead. And on a sort of a broader note, I remember when I started this whole journey of type 1 diabetes here in Goa Medical College, there's some children who started off with us. Today they're not there with us. So if Sushant would acknowledge, probably the number of people who got registered in our clinic, probably to meet me once, or probably meet Sushant, or just be part of the journey with Goa Medical College, would have been nearly 1,000. Today, I think so there are, with us who are regular, there are around 200, 250 odd. It's not that the others are not there, they just do not follow up. So if we had a center of excellence here, then we would see to it that we give them the best of care. And that would sort of encourage everyone to be with us forever. As long as they are in this world with their journey of diabetes, they would be with us. At the Olney Institute, when I was there, we had at least 2,000 people who were registered in the clinic, the DOI clinic. And if you ask me how many were regularly coming, hardly 400. The same problem. So how to solve this problem is to have a center of excellence, where you give dedicated care to these people and they feel empowered there. So these are the things which I'm looking out for the next few years. Let's see how the journey goes. Yeah, done. Thank you.
Thank you, Dr. Ankush.
I am here just to inform you that we at the Directorate of Health Services, what are we doing to achieve this for our community and for the children itself. So we believe in early detection and prevention. For that, we are prioritizing the early diagnosis and prevention through regular health screenings and awareness campaigns. Our healthcare centers like PHCs, CHCs, district hospitals, medical college are all equipped to provide accessible and affordable care, wherein free drugs and diagnostics including insulin is made available at all the government health centers. In case of comprehensive care, we have established specialized foot care and ophthalmology clinics to address the specific needs of individuals with diabetes. These clinics offer timely interventions to prevent complications. Leveraging government initiatives, we are actively integrating our efforts with the Ayushman Bharat Health Scheme, now known as Ayushman Arogya Mandir. This scheme provides financial support to patients, enabling them to access quality health care. Innovative digital solutions, we have launched a comprehensive digital diabetes registry to track the number of people with diabetes monitor their health parameters, and allocate resources effectively. This digital tool will help us identify trends and implement targeted interventions. Promoting a healthy lifestyle. We are promoting healthy lifestyle choices, including a balanced diet, regular physical activity through the NCDC health camps, and Eat Right initiatives. Just to inform the House that we are getting CSR partners for continuous sugar monitoring for our patients very shortly. So our ultimate goal is to create a diabetes-friendly environment where individuals can live healthy and productive lives. So by working together, we can reduce the burden of diabetes and ensure a brighter future for the generations to come. I urge everyone to prioritize their health, adopt healthy lifestyle habits, and seek timely medical attention. Let us all join hands to combat diabetes and create a healthier Goa. Thank you.